I'm an old nurse, and I've been doing this for many, many years, and I still do it. I work with people with disabilities living in care homes, and have done a lot of work. I'm also facilitator for grief support groups. But I have three different questions. One being, everybody in this room needs to know that and get their advanced directive, pulse, whatever you want to call it, done. Every single one of us, regardless of our age, if we don't have it, we need to do it. Because that helps them for what you were talking about, that hard time when the rubber meets the road. You've got that, and see, this is what mom wanted. Or your child. You know, your child can fall and have a brain injury and not be able to make decisions for themselves. But yet they're a young adult or, you know, a parent or whatever, but small children, and somebody needs to make those decisions for them. So I'm really a proponent on getting those things done because I think it helps. It sets you at ease. Even if you don't agree with the decision, it helps. The situation back here, I've had many of the individuals that we serve who have not had the opportunity to go to a home like you're describing back here due to that $300 because they didn't qualify and they didn't have the funds to be able to do that. That's a real inequitable thing in our society, and another thing that I think, come on, Wallace, let's get the job done here. Let's do what we need to do in this Minnesota government and get this taken care of. Palliative care. I've been in this business a long time, and there still is gross confusion between palliative care and hospice care, and how a person might transition from one to another, how a person might have them overlapping. And regardless of facilities and from Doulas in that area, the facilities that we work with, the two hospitals we have up there, you can never get a real good definition. So my question for you, Drew, is should we still be confused about this? Is it murky, the transition between the two, or how do we know how to explain that to caregivers?
You know, this is the date of my existence. That's kind of a joke. It's not a big deal. But it is a constant source of discussion and confusion. And I think it genuinely is confusing. Like, and again, it comes down to the fact that palliative care is 5 different things. And so, anyway, I think most of us who do, for the program that I'm a part of, I never, ever discuss our program as being in any sort of relationship with hospice care. It's not a pre-hospice program. It is not an alternative to hospice program. Like, I don't talk about hospice. But I want to say that because I love hospice. I refer many of my patients in hospice and follow them and see them when they're in hospice. But it's more confusing to the public than it is illuminating to say palliative care is a pre-hospice program or something. Right? There's nuggets of truth in that statement, for sure, but it's just confusing. And part of the reason why it's confusing is because hospice is an entire thing. It is a federally mandated package of medical and social services that provide, we all wish there was more, as we're talking about, especially but provides relatively comprehensive medical and social services for terminally ill patients and their families living in the community. Like, it's like a big thing. There's a law and federal rule that tells us how this is. And there's nothing like that for palliative care. Again, palliative care is more like cardiology and infectious disease than it is hospice. What we do is focus on quality of life and support. So there's a hospice vibes to it. But it's not analogous to hospice. And so it's more confusing to talk about it that way. And the other thing about it is that, again, I think it's in the U.S., most of the patients who are being seen by palliative care specialists do have life-limiting diseases However, our programs are not exclusive to permanent ill persons. They're not end-of-life programs in any sort of particular exclusive way. And again, like I said, like about a third of my patients are getting cured from their cancer, or they're going to get a lung transplant, and they're just like they're not dying anytime soon. We hope we think, right? Any more than any of the rest of us are, right? And so it's confusing to sort of talk about palliative care as having some sort of specific context with end of life. It's more, and so this is why we just like don't even mention hospice. When we're describing what our program is. And I think that's how it should be approached with everything else. Again, I will say, what's confusing about this is that there are people who are trying to create home-based palliative care, home caring programs that are similar to hospice, that provide similar services to people who could be in hospice, or maybe who will be in hospice but don't qualify yet because they're still getting chemo or they're still whatever. And right, people are trying to invent those programs. In parts of the country, we have these little programs doing it, and it's very mixed right now out there. And these programs are great. We need these programs. The Lord knows we need these programs. But they're also like different than like the program that I'm a part of, right? And I mean, there's a different type of palliative care. And that's what makes it really confusing. I don't see I don't see any future where we're gonna get out of it. And I think if these home care programs are successful, and Jeff and I were talking about it this morning, like they're not there because like there's no federal funding mechanism for these programs, and so like it's really tough to make them. But anyway, if we someone figures out how to do this in the next 10 years, or like President Harris like funds it or something like that, there will be all these like home care palliative programs, and it will be wonderful, and it will improve the quality of life of my patients and their families, and I will love them. And it will confuse what the heck palliative care is. And it's like that's what's going to happen, and we're going to have to live with it. And yeah, I'm done.
I just to add on, and correct me if I'm wrong, one other distinction, or a couple others that tend to be helpful with hospice to palliative care is they're both comfort care, right? We care about the comfort for the patient. Hospice, like Drew was saying, has these federal mandates in terms of two physicians have to sign off saying they believe life expectancy is 6 months or less. So that's hospice. Palliative care does not have that regulation of a timeline. Hospice does, although people can live longer even when given that timeline. And also in hospice, people cannot pursue curative treatment measures. It is purely comfort care versus in palliative care, you can be having these comfort cares but still be pursuing some treatment, curative treatment, and that's not the case in hospice. So it is murky and tricky, but those two distinctions can help people a little bit.
Like people who are near the end of life, who mostly want comfort care, focused end of life care, they may still want antibiotics here and there. Like that's okay, that's fantastic. And so good hospice agencies work and support their patients and families through that, and it's okay.